Good morning. It's a real pleasure to be here. This is an exciting conference. So today what I thought I would do is tell you a little bit about the near past, about today, and then consistent with the theme of this conference, to peer into the future a bit to see what we might look forward to as far as methods for improving outcomes for people with serious mental illness. So before I start, I just need to tell you that I have no financial conflicts that are associated with this talk. And I'm also here as a division director at NIMH, but anything that I say you should take as my personal opinion, and don't expect that the federal government will follow anything that I say to you today. So what I would like to do is to tell you a little bit about the NIMH initiative, Recovery After an Initial Schizophrenia Episode, and where that has brought us today, and then to use RAISE as a platform to talk about how we might move into the future using many of the strategies that are at the heart of this conference. So RAISE, it stands for Recovery After an Initial Schizophrenia Episode, and really the title of the initiative says it all. We're looking to promote recovery in individuals who are early in their experience of illness and trying to improve, not only improve their outcomes, but actually to restore a normal trajectory to their lives so that they have a very good chance to become fully participating citizens. Why did NIMH take on the RAISE initiative? Well, we started thinking about this initiative in 2006, 2007, and as we looked at what were typical outcomes for people with schizophrenia at that time, it was pretty apparent that this is a significant public health problem and that we hadn't achieved significant traction in achieving better outcomes. So I don't need to belabor these points to this audience. You know that there are many millions of people in the United States that suffer from schizophrenia and related disorders. In most cases, the overt signs of illness begin in adolescence or early adulthood, just at the time when the person is beginning to move into adult responsibilities and taking on adult challenges. So it really disrupts education, it disrupts social relationships, it disrupts the ability to participate as a member of our larger economy. Schizophrenia tends to be characterized by multiple episodes of illness over the course of the person's lifetime, and this has a tremendous impact on their functioning. Unemployment is very, very common. 80 to 90% of people with established schizophrenia are not able to work, and between 15 and 20% of people with schizophrenia at any given time are either homeless or are incarcerated. Recently, we found that people with schizophrenia die anywhere from 8 to 10 years earlier than people in the general population. And sadly, this is either a small portion of this is related to suicide, but this shortened lifespan is really more explained by medical comorbidities that are highly treated but are often undiagnosed and are not treated with available medical care. So on top of the personal burden, the personal suffering, the burden on families, there's a tremendous societal burden to schizophrenia. It was estimated in 2005 that the total cost of schizophrenia to the United States was approximately $63 billion. So in 2005, 2006, we had a very, very big problem. We didn't have, we had some ability to help treat the illness, but our prevailing paradigm was one where we waited till we tended to institute treatment several years after people were ill. By that point, they were already disabled, and then the treatments that we offered them were more in a disease management framework, where we tried to manage symptoms rather than promote recovery. So against that backdrop, we thought about how might we do things differently in the United States. And here we had the benefit of research that was being conducted in Australia, in the United Kingdom, in Canada, in Europe, that was really approaching the problem from a different perspective and looking at what would happen if we offered interventions early in the course of illness? Could we change the trajectory of schizophrenia? And the evidence at that point in 2005, 2006, 2007 was there really was a chance to do this, that if we emphasized early intervention, we might be able to achieve better outcomes that would put people on a recovery trajectory. So in RAISE, we were looking to emphasize early intervention. We were looking to emphasize the prevention of disability or full recovery. And then two other things that we were looking to do in this initiative was to build something that would have immediate relevance to the US public health sector. So we wanted to build an approach that could be implemented in community mental health centers. We had a very, very good idea that if we left it to our academic centers of excellence, they would be able to create an intervention that would be highly effective. But because those centers tend to be highly resourced, that approach might not work in the real world of clinical care. So we asked, actually we demanded that this initiative be conducted in the real world community settings, using clinics that had no prior experience with first episode care, no academic affiliation, that we would retrain the existing clinical workforce to provide this treatment, and there would be very few exclusion criteria on the people who would apply. So we tried to build the study so that that the results would be broadly generalizable at the conclusion of the study. And then the last thing was we were looking to take a different approach to the question of implementation or scalability. Typically, you need a series of studies that build incrementally. They move from the laboratory into the clinic, and you develop a body of knowledge to say, okay, we have a finding that can work in the real world. Here, we wanted to see if we did the study in the real world, and if it was effective, we wanted the investigators to produce the tools that would make this scalable immediately. So those were our aims in 2008, and we ended up funding two studies. One was the RAISE Early Treatment Program, which was a randomized clinical trial. John Kane and his colleagues were the leaders of that project. And a second project, the RAISE Connection Program, which was an implementation study led by Lisa Dixon and her colleagues. And I'm going to tell you a little bit more about each of those projects as we go along. First, the clinical trial. This was a very ambitious endeavor. There were 34 clinics that were selected after a national selection process. They had those real-world elements that I mentioned previously. 17 of those clinics were randomly assigned to give an experimental intervention that I'll describe in just a minute, and 17 of them were randomly assigned to provide typical care in the community. So there were 404 individuals with a first episode of psychosis that were enrolled in this study. It utilized, as I said, real-world clinicians who were employed in these centers and retrained to give a particular type of treatment. And the things that we were interested in assessing in this study were clinical and functional outcomes, as well as cost effectiveness and overall societal benefits. So the type of treatment that was applied here was, you wouldn't call this 21st century. It was actually culling the most proven treatments of the 20th century and putting them together in a package that made sense for young adults with first episode psychosis. So there was an emphasis on using stage-specific pharmacotherapy with close integration with primary medical care, so that these problems of medical comorbidities, if they occurred, would be caught quickly and could be treated efficiently. In addition to that, an individual psychotherapy was developed that emphasized resilience and recovery, built upon evidence-based approaches that had been tried, had been tested in a variety of trials. Family psychoeducation and support was included. We know that the experience of first episode psychosis is very traumatic for the family. Often family members are unsure about what is happening with their loved one. They're even less sure about what they can do to help that person recover. So this particular intervention was designed to address those needs. One innovation in this approach was the inclusion of supported employment and education. While supported employment is known to be effective in helping people with established psychiatric illness return to work, the literature really was very sparse in first episode psychosis. So the investigators took on the task of adapting an approach that not only worked towards vocational outcomes, but actually could address the needs of a younger population where the demand was to return to school. And then finally, with all of that, case management to help weave together the various services, and a philosophy that emphasized shared decision making. So this is one where there's a respectful collaboration between the person receiving care and the team that is offering care, so that treatment is tailored to the needs and the preferences of the individual, and treatment planning and treatment adjustment are really an ongoing conversation over time. So in the RAISE clinical trial, this approach was called Navigate intervention, and it was compared to usual care. So the results of this study were published just about 10 days ago in the American Journal of Psychiatry. And I'm going to present to you just 2 data slides from that study. So I'm going to spare you all of the details, but give you some of the highlights. So we were interested in the primary outcome for this study was quality of life, which was a measure that took into account the things like symptoms, interpersonal functioning, engagement with the community, and also the person's experience of recovery as indicated by things like curiosity, motivation, interest, and engagement. So on this overall measure, we did see that there was a significantly different rate of improvement in these 2 conditions that favored the Navigate or the experimental condition. So people in Navigate, you can see on this slide, those are the people in the red line, they actually started off the treatment in a somewhat worse position than people in community care. But by a year, they had caught up to those individuals who were also improving, but at a slower rate. And by 24 months, they had outstripped that group. So this was a positive finding, and one that told us, on average, people with the Navigate intervention were going to do better than people who were receiving typical care. But I draw your attention to that Cohen's D figure down there, Cohen's D 0.31. This is a measure of effect size, or so beyond statistically significant differences between groups, how likely is it that an individual is going to demonstrate an observable difference in their behavior? And effects, so this gives you a metric for evaluating the clinical significance of a finding. A Cohen's D of 0.31 translate into a difference that a mental health professional would notice. So over a period of time, a mental health professional looking at a person in the Navigate treatment would say, this person is better. Clearly, they are better. So that's a good thing, but we also want to know, are we getting results that translate into noticeable findings for the individuals themselves, family members, teachers, and so forth? And here, this was, we get a perspective on this when the investigators looked at the analysis in a finer-grained manner. And here what they did is they looked at the interaction between the treatment and the length of time that the person had been ill prior to the initiation of treatment. So duration of untreated psychosis is known to be a variable that's important for determining the kind of prognosis for people with schizophrenia. The longer you're ill without receiving adequate care, the less likely it is that you're going to respond to treatment when it's offered, and the lower your recovery ceiling is going to be. So the shorter the duration of untreated psychosis, generally speaking, the better the outcome. So in this sample, the median duration of untreated psychosis was 74 weeks, or 18 months. So half of the sample was ill for 18 months or less prior to the initiation of treatment. half the sample 18 months or longer. When they put that into the analysis, you can see that there's a really robust interaction with the treatment. So the red solid line at top shows you what happens when you give the Navigate treatment to people who are ill less than 18 months. You get a very large effect. So that Cohen's d of 0.54, it almost doubles the effect that you get in the group analysis, and it tells you this is a noticeable difference. People experience themselves as better, their family members see them as better. Not only clinicians, but teachers, employers would see the person as significantly improved. So this tells us something. It tells us that it's important to give the right kind of care to individuals, but it's also important for us to be mindful of when we're offering the care. So not only developing programs like the intervention tested in RAISE, but also arranging things so people are identified quickly, referred to the care in an efficient way, and then we would expect to see these outcomes. So this is where we are today. So RAISE had 3 aims. The first was to establish, can we take the kinds of approaches that have been tested in other countries? Is it feasible to create that kind of approach in the United States using within all of the constraints that our healthcare system exerts upon this kind of treatment? And the answer to that question appears to be yes. So in the RAISE clinical trial, they were able to establish 17 programs. They trained well over 100 clinicians. Each of these clinicians achieved competency in the various areas of the roles of the treatment program. And the programs successfully operated between 2010 and 2014. Illustrating that they were able to be maintained over time. So can we make something like this work in the United States? The answer to that appears to be yes. Then the question is, if we do it, does it make a difference? Well, the outcome data, again, seem to say yes, it does, particularly if we pay attention not only to the type of intervention, but also to timing. So that leaves us with the question of scalability. Did we build something that actually can be erected in the real world as we know it? And here, RAISE got a big assist from the Congress. And it turned out, I won't tell you the whole story, but they were actually watching this project as it unfolded. And in late 2013, they decided to add additional funds to the Substance Abuse and Mental Health Service Administration that would support the types of programs that were tested in the RAISE project. And they also asked SAMHSA and NIMH together to work to develop guidance to make that information available to the states. So the RAISE implementation study really was a tremendous asset in our developing guidance for the states. Those projects focused on the kinds of issues that would need to be surmounted to be able to develop this kind of program and make it work in the public health setting. A key advantage of those programs was the partnership with the mental health commissioners of the 2 participating states. In New York, that was Michael Hogan, and in Maryland, it was Brian Hepburn, who were active participants in the project and really helped guide the program to keep its focus on real-world solutions to surmount the barriers to implementation of this kind of project. And that program was very successful in producing products that have been made widely available. These are the publications, but the actual manuals, videos, program operation materials are available at no charge through the NIMH RAISE website. So all of that was good. So the Congress, we had some tools, the Congress gave us more money. What's the impact of this, the science and the policy opportunity in terms of implementation in the United States? Well, one way we can look at that is ask, well, how many states had plans for early intervention services in 2008 before the RAISE project went into effect? And the answer to that was there were 2. It was Oregon had a state plan dating back to 2001. California followed in 2005. And after that, there really was no state plan that had embraced this kind of treatment as part of the state mental health policy. Well, as states responded to this opportunity that Congress provided, SAMHSA was collecting their plans. NIMH and SAMHSA evaluated their plans, and we were able to look in 2014 how many states had concrete plans to adopt early intervention and plans to develop one or more of these kinds of integrated treatment programs as tested and raised. And what we see is that by 2016, the world will be very different. We'll have 32 states that have signed on to this kind of approach, and each of these states will have one or more operational treatment programs. As we count up what the states have promised to do, there could be as many as 120 of these clinics available in the United States by the end of next year, which will really represent quite a tectonic shift in the way that we approach early intervention in the United States. We got a further boost just 2 weeks ago. On October 16th, the Center for Medicare and Medicaid Services announced that they provided an informational bulletin to state Medicaid directors that endorsed coordinated specialty care as a treatment for first episode psychosis, and they provided instructions about how various Medicaid mechanisms could be used to implement this treatment broadly. So now we have science, and we have 2 policy decisions that make it possible. And that's where we are, the world today. Now we can ask, well, with that platform, how do we think about the future? And that's what this conference is about. So I have a couple of thoughts about that. And so where do we go from here? And the thoughts are about how we could improve treatment quality, how we could improve treatment outcomes, and how we could maintain treatment gains. These are 3 areas that remain unresolved after RAISE and will need further investigation. So the first is workforce development. We know in the RAISE study, there was a strategy for training people, for supervising people, and giving them consultation. It was impressive that they were able to do this in 17 sites. But if we take the numbers and we extrapolate, by the end of 2016, we'll need somewhere between 400 and 600 people trained in the United States to do this. And if we think about if this is broadly implemented, given the size of the vulnerable population and the extent to which we embrace the goal of offering the service to every eligible individual, we could be in a position where it's estimated that somewhere between 1,000 and 3,000 of these clinics will be necessary in the United States to meet the need, which means that there will be several thousand of clinicians that will need to be trained. And when you account for turnover that happens in programs like this, it means that there's going to be a need to have an enduring capacity to train people and to train them, to certify them, and once they're certified, to offer ongoing supervision and consultation so the quality of their treatment remains high. I've been interested in just been thinking about what kinds of strategies might we embrace to achieve this, and thinking about things like the Khan Academy, which has really kind of revolutionized the way that we do, the way that different types of educational opportunities can be offered to a broad population using different types of medium, different styles of coaching, different styles of updating information, that this provides us one possible strategy that has been used in other areas of healthcare, but it suggests we need something that's going to be able to be independent of geography and of time zone, and be able to take advantage of things like virtual learning communities, virtual supervision sessions, and so forth, to be able to maintain the workforce. The next thing that we can do for quality is think about clinical decision support systems. These have been developed in a number of areas where we give clinicians information about the response of individuals to treatment, the sequencing of treatment, the response of the individual to treatment. That part's not new, but what's beginning to emerge is to have databases that are augmented with artificial intelligence to actually help the person understand their individual patient's response in terms of expected outcomes for a population, and then also suggest to them, based on the empirical literature, what kinds of modifications to the treatment might make sense to them. So this is another place where we could expect that these programs could enhance the quality of the care. What about boosting outcomes? Well, you've had some, Adam Ghazali gave a talk about cognitive training for an elderly population. Bruce Wexler is here, a pioneer in cognitive training in schizophrenia to offset cognitive deficits. We know that people with first episode psychosis also experience cognitive deficits. And there's been some work to show when you combine cognitive training that targets attention, memory, problem solving, you add that to a supported employment approach, that you can double the effect size there. This is something that hasn't been tried in first episode psychosis, but when we think that young people need to get back up to speed to return to school, to be prepared for the cognitive demands of work, this is a very reasonable area for further exploration. We could also think about enhancing the cognitive behavioral recovery therapy that's offered to individuals by using smart technology. This is an area where there's tremendous interest. There's not a lot of data, but there's a lot of promise. And using smart technology to extend the reach of cognitive and behavioral interventions so that people can use these tools in their their 24/7 existence would be an area that we might expect that we could bolster the effects in that domain. And then finally, the last thing that I'll mention is that we do know from this literature that worldwide, you get a pretty good outcome during the initial treatment phase, and after 2 or 3 years of treatment, when people are returned to the traditional mental health care system, there's a fall off of the effect. These are results from a trial in Denmark, the OPUS trial, that showed that for positive and negative symptoms of schizophrenia, there was a significant advantage for this integrated care in the first 2 years of treatment, but at 5-year follow-up, there had been some slippage in the effect, so that there was no longer a significant difference between the two groups. And this similar findings were found for global functioning, for substance abuse, and course of illness. So people have been wondering, what do we need to do to maintain this effect? And one strategy that's been suggested, or one thing that has been suggested, is that what people lose when they leave these programs is they lose the sense of community that surrounds them. They lose the treatment team, they lose the peer support, they lose a community of people who are engaged in a similar set of struggles and a similar recovery journey, and that's a very important loss. And we can look, I know that there was a presentation here about the big white wall. That approach has been translated in Australia into a program that generally speaks to youth who are experiencing mental health difficulties in a variety of areas. And in Australia, they recently have been looking within this Headspace initiative. Is there a way of carving out a place for people who have been successful in first episode psychosis treatment programs where they can find an online community that also includes access to professionals that can help consolidate and maintain their gains over time? So this is my last slide, just to say, knowing that the Maryland Mental Health Association is part of the larger organization, NIMH is all in with the goal of before stage 4. We believe that the future is in exploring opportunities for earlier identification, earlier intervention, and offsetting disability or preempting disability before it takes hold, so people have the opportunity for full and productive lives. And that's the end of my presentation, so I thank you. And if you have questions or you'd like to chat about these initiatives and others, you can contact me at my email address at NIMH. Thank you very much.